Wasif, to you.
All right. Thank you, Bashir, again for the opportunity to present. Again, this was it's not an easy talk to put together because it was just information was all over and nowhere available. So I'll tell you what we do at our institution. We talk about TAVR or TAVI, LAO, and then tier privileging. So for TAVR, applicants must be board certified, eligible in cardiac or cardiothoracic surgery, interventional or pediatric cardiology. Can you hear me? Can you all hear me?
Yes.
Yes. Okay. Perfect. So they've previously completed procedures required to apply for privileges. And they've completed all vendor-sponsored training for the surgeon and interventional cardiologists. Minimal required training is 100 aortic valve replacement, including 10 high-risk patients. Minimum of 25 AVR, or minimum of 50 AVRs, and which include at least 20 AVRs in the last year prior to the TAVR initiation. I'm sorry, there's some background.
Yeah, I know. Dr. Sumro, can you please mute yourself? Dr. Khalda Sumro, can you please mute yourself?
I'm just waiting for them to mute because it's kind of confusing me a little bit. Great, excellent.
Okay, go ahead.
So for interventional cardiologists, we have 3 pathways. Pathway 1 is completion of a formal structural fellowship with TAVR training with minimum of 50 cases. And they then need to give us the documentation for those cases. There's focused professional practice evaluation, FPPE, and the first 5 cases under concurrent proctoring within the system. Pathway 2, it is prior clinical TAVR practice with minimum 50 cases as first or second operator, at least 20 within the past 12 months with satisfactory performance. And FPPE requirement for the institution means documentation supporting prior clinical TAVR practice with minimum 50 cases as first or second operator, or at least 20 cases in the past 12 months. And then the first 5 cases are again under concurrent proctoring within the system. And pathway 3 is completion of interventional cardiology fellowship within the past 5 years with active participation in TAVR procedures, but not training to competency. And after completion of vendor training, may request the privilege and remain under concurrent proctoring until competence with performance of procedure and management of associated complications has been completed. And in this, participant should attend 75% of weekly conferences, participate in 50% of scheduled cases, and the first 60 cases are under concurrent proctoring with 25 as primary operator. There has to be proficiency in usage of large caliber closure devices and proficiency in management of TAVR complications post-procedure. Renewal of privileges required to perform within previous 2 years. Past participation in National TAVR Registry, follow-up of all TAVR patients. All physicians privileged for TAVR must attend 75% weekly heart team meetings and participate in evaluation of patients. Interventional cardiology and cardiac surgery, minimum of 25 aortic valve replacements annually, or 50 in 2 years. For cardiac surgery, minimum of 20 AVR in the last year prior to TAVR, and satisfactory completion of all commercial and CMS TAVR practice requirements. And you also are required to get 20 CMEs every 2 years. So this is something that we have had every operator in our facility do. We have 7 TAVR operators in our facility, and it's important to be part of the meetings as well as part of the registry, and follow-ups are extremely important for these patients. For left atrial appendage occlusion devices, the procedures must be performed by interventional cardiologists, EP, that meet the following criteria: have received training prescribed by the manufacturer on the safe and effective use of the device prior to performing the closure devices, have performed more than 25 interventional cardiac procedures that involve transseptal puncture through an intact septum, and continues to perform greater than 25 interventional cardiac procedures that involve transseptal puncture through an intact septum, of which at least 12 are LAAC closure. over a 2-year period. So this is important because, again, this being a transseptal procedure, we have to make sure people are proficient in performing this procedure. For mitral clip procedures or for tear procedures, it is for the treatment of symptomatic, moderate, severe, or severe functional MR when the patient remains symptomatic despite stable doses of GDMT, plus cardiac resynchronized therapy if appropriate, or for treatment of significant symptomatic degenerative MR when furnished according to a FDA-administered approved indication. So again, this is all decided with the heart team approach when these patients discussed. And the procedure is furnished with a mitral valve system that's received FDA pre-market approval. Again, the patient is preoperatively and postoperatively under the care of a heart team, a cohesive, multidisciplinary team of medical professionals. The heart team concept embodies collaboration and education across medical specialties to offer optimal patient-centered care. The heart team must include the following members with experience and training as specified: a cardiac surgeon with greater than or equal to 20 mitral valve surgeries per year or greater than 40 over the last 2 years, with 50% of them being mitral valve repairs, and who is also board eligible or certified in cardiac surgery or similar foreign equivalent. For the interventional cardiologist, with professional experience of greater than 50 career structural heart disease procedures or greater than 30 left-sided structural heart procedures per year, with participations greater than 20 transseptal interventions, including 10 as primary or co-operator, and who is board eligible or certified in interventional cardiology or similar foreign equivalent. For the interventional echocardiographer, either the cardiologist and anesthesiologist, they have professional experience of greater than 10 transseptal guided procedures and greater than 30 structural procedures, and who is board eligible or certified in TE with advanced training as required for privileging by the hospital where the procedure is being performed. And then we have heart failure cardiologist experience in treating patients with advanced heart failure. This is only required for functional MR patients, and providers from other physician groups, as well as advanced patient practitioners, nurses, research personnel, and administrators who are taking care of these patients as well. So mitral valve tear procedure must be furnished in hospital with appropriate infrastructure and experience that includes, but not limited to, on-site heart valve surgery, interventional cardiology programs, post-procedure intensive care facility where personal experience in managing patients who have undergone open heart procedures is being done. Hospital volume requirements must be met and maintained. Greater than 20 mitral valve surgical procedures for severe MR per year or greater than 40 over the last 2 years, of which at least 10 or 20 over 2 years must be mitral valve repairs, and more than 2 physicians with cardiac surgery privileging experience in valvular surgery, and 1 physician with interventional cardiac privileges, and more than 300 progressive interventions per year. And that's all I had.
Thank you very much, Wasif. I really appreciate it. I think if we have any quick comments from our panelists or any questions, and then we'll close the session. It's been a long session, and I can't thank enough everyone who has been sitting there since from the beginning of the session.
Just quickly, a few comments. Every cath lab in our part of the earth should have a root cause analysis program to start with. Like one of the talk was about complication. So we should be routinely doing RCAs. And another very important is focus PDCA. That is sitting the team, discussing the failure and then the outcomes and coming up with the solution. So I think that should be the norm. We should build up and doing monthly at least M&M. So that's very important to bring into our practices.
Agreed. Dr. Ashok?
Well, again, in short, it was a real wonderful session, excellent talks from all people, got a bundle of knowledge in a very short period of time, and I think it was great to have this kind of a session, especially the talk about the medical director for the cath lab and the role of that, and then subsequently I really enjoyed the talks of how to get time off or try to enjoy your time off or get away from the work. All these are kind of things. I just want to share you in 30 seconds. I always tell my wife during my residency, when I will be fellow, I will get more time. And then when I got an interventional fellowship, I told, now I will be having more time for you. And then I will got a consultant. Okay, I will have more time for you guys. This never happened. So I think we all are in a situation we need to work. I thought in Pakistan we will have more time. It's the other way. Believe me, this is very, very important for us to make sure we get enough time. And last thing I would say, I really enjoyed your talk about how to make your cath lab team happy. It's a very, very important for a successful procedure and for your life. Thank you very much from our side.
I think you rightly said it, and I would like to quickly share one story also. I moved back from US like 15 years ago, and one of the incentives I gave to my wife that I will have more time and I'll be able to spend more time with the family and you. And she agreed to come back, and over here I have actually more busy than over there and not able to give any time at all. So all of us are busy, and I think all the talks were great today, and I think we really enjoyed the talks, learned a lot, and I'm sure these talks are going to be kept as a recording on our website, and it's going to be used probably by all the cath labs. It was a great session, and I really don't have words to thank Sky, especially, as I said, Elizabeth, for helping us to basically get together this session, Dr. Faisal Latif. I see, I think Eric is there too. Eric, thank you very much for coming. Do you want to say anything quickly? I don't know, probably he's not there. So I think with that, I would end the session. We had a long day. We started at 7 o'clock. It's like 7:40 p.m., over 12 hours. But still, we really enjoyed the session. And I thank all the speakers for staying there. Dr. Peter Duffy has been there all the time, and Dr. Reeves and all other speakers. Dr. Wasif Qureshi, thank you so much. We are very grateful to Sky and all the speakers. Thank you.
Thank you for inviting us.
Thank you.
Thank you very much, Bashir.